Hi there, my name is Vic Veer. I'm an ENT surgeon working for the NHS in central London. I'm currently working at the moment. I've got a few minutes just before my operation. I'm on call over Christmas, which is fine. It's part of the job. But I do have a few minutes to do this Ask Me Anything type questions. And this will be first of these sort of short videos because I've just been away in New York learning some different types of surgery. And so I'll be telling you about what I've learned in New York in the last week. And but back to these questions anyway. So I'll be putting the questions at the bottom here, and I'll just be going through the list as I go through. So the first one was, in a upper airway resistance syndrome video, you talked about a lot of patients having nasal and lingual tonsil issues. Okay, so what I meant by that is that there are lots of different subgroups of people with upper airway resistance syndrome, but a very common one is the young, tall, thin man, typically, who has very bad tiredness. And when you look at these people, there are two classes of people. They're the people who just have very bad nasal obstruction, because the sleep study can be fooled by nasal obstruction. So people look at the flow limitation and things like that. And flow limitation, if you don't look at it properly, will make it look like you've got upper airway resistance syndrome, when really it's just flow limitation because their nose is blocked, not because their airway's having a problem. Because you can always tell, because the flow changes quite significantly when you're in different positions. So it should be worse when you're lying on your back, or it tends to be worse in these people. But anyway, if it looks like they've got a slightly raised RDI and a high flow limitation, it's sometimes just a nasal obstruction. You'll deal with the nasal obstruction and then everything just goes away and they don't feel so tired. It's like the tiredness that you get when you constantly have a cold or a flu. You just feel just dreadful all the time. If your nose is blocked, you're going to have difficulty. But there are some people who clearly do have upper airway resistance syndrome. And when you look at it, they tend to have a tongue base that seems to be falling backwards. Now, again, unblocking the nose can help the tongue. I know that they're not directly anatomically attached or associated, but they are sort of physiologically associated. I've said this in some of my other videos. When you unblock the nose, when you're lying on your back and the nose is blocked, people have to sleep with their mouth open like this, and that's how people sleep. But the problem is, no one sleeps like this. Everyone sleeps like this, and their jaw just falls right back, and that jaw falling back with the tongue following along with it blocks the back of your airway. So when you unblock the nose, it takes a few weeks to get used to this, but when you unblock the nose, you can start breathing again through your nose again. You sort of rehabituate yourself to start breathing through your nose. So then you go from like this with your jaw falling right back to closing your mouth, keeping your mouth shut, bringing your tongue forward, and therefore opening up your airway just by simply opening up the nose. Now, that's why, another sort of sideline, I don't like mouth tape because it just holds onto your lips. It doesn't stop your jaw from falling back. And that's why I quite like a good quality chin strap, one that closes the mouth but doesn't pull the tongue back like those, or pushes the jaw back like that. So that's why I like the Knightsbridge chin strap, and you'll see a video somewhere in there as well. So back to the question. Upper airway resistance syndrome people tend to be, well, this subgroup tends to be tall, thin, young men, very, very tired. Sometimes unblocking the nose helps, but sometimes also, once you've unblocked the nose, also when you've done a drug-induced sleep endoscopy, I tend to see people at this age group having a large lingual tonsil. Some of them have already had their palatine tonsils taken out, but the lingual tonsil is still very large, which tends to happen. And when you look down there, you see, although they're closing their mouth, the jaw's forward, they still got obstruction from their lingual tonsil. You just shrink that down and everything gets better. And there's various surgeries, which is the most common. So this is a two-part question. So the problem with getting videos about surgery on my channel is that it sort of looks like I'm trying to get loads of views. I think some videos are really useful to look at, but I'm not trying desperately to get loads of views. I'm trying to make videos which are helpful. Watching videos it's not my thing. I just want to make videos which are useful to people. And seeing a video, I think, for example, I just did one on expansion pharyngoplasty, and it's quite gory, and a lot of people sort of feel sort of repulsed by it, which is understandable. It's not a nice operation to watch, particularly on someone's throat, when you're moving muscles around and opening up and pulling their throat up. It's not but it's difficult not to keep watching if you can. You see these people with who are picking out blackheads out of people's faces. It's sort of this sort of embarrassing bodies type thing, and it's not my thing. I mean, I'm not saying it's bad in any way. It's just I don't want my YouTube channel to be just operative videos that people watch. I want something to be useful in my channel. So I will be doing some videos, but I do try and make it less gory if I can. And I put the videos out because I think it's useful for people rather than just trying to get views. Anyway, look, I'll leave that bit. So there's another question about silicone earbuds. So does it cause wax? Yes. Well, if you're pushing and sealing off an ear canal, it doesn't allow the wax to naturally migrate out sort of through this transport system, which you'll see in my earwax videos. So yes, it does do that, but try not to use them if you can. If you are going to use silicone buds, try and use some drops just to dissolve out the wax, which can start building up just on the most lateral part of the ear canal. So question related to migraine, Eustachian Tube. Okay, so there's a question here which it's difficult to tell. I can't give medical advice online, but it's difficult to tell from what you've said if this is a migraine or if it's Eustachian tube dysfunction or if it's a sinus barotrauma type thing. They are sort of linked, but it really depends on the symptoms. You've just got to go and see someone and get them to look at you, look at your ears, look at your sinuses, sometimes even doing a CT scan. That will probably help you out and find out why that helps you. That stopping the eardrum from moving, that's what you're doing with the silicone bud, particularly if you made it airtight inside there. Which patients had the biggest impact on my life? So yeah, I don't like talking about individual patients, but there was a young girl who was disabled, and she had a life-threatening problem, and I'm not going to talk about it, but I was told 100% do not do this operation, what's the point, she's going to die anyway, all these sorts of things. And I'm sure if she's still alive or if the parents are watching, I'm glad I still did it, because she was very lucky to get through it, and she survived, and I'm very happy. And I felt very brave at the time, because they said if you do this operation you're going to lose your job, all this sort of stuff. But I felt that everyone was just scared to do this operation. They were worried about their own career, but the family wanted their daughter to live. So I did it anyway, and I was lucky she survived. I just don't want to be one of those surgeons who's constantly worried about their career. I feel like I wanted to be the surgeon who isn't scared and will just talk through the problem with a patient. And as long as they know the risks, and you'll see my videos, a lot of my videos are talking about the risks and the side effects, the complications, things like that. As long as someone really understands an operation and they want to go ahead, and as long as I think it's there's a reason for them to go ahead, then I think we should just go ahead with these things. And every time I think to myself, oh, maybe I shouldn't do this, it'll be bad for my career, I sort of think back to that young girl and think, look, I was brave then, why can't I be brave now? And let's just talk it through, make sure everyone understands exactly what's going on. And if people do understand what's going on, then, and that they know what the risks are, you should go ahead with the operation, even if all your friends and colleagues are telling you don't do it, because sometimes you have to be brave in medicine. It's scary, because you're trying to deal with people's medical conditions, their lives and things like that. Trying to make the right decision is hard, particularly when there are no rules and algorithms for certain things. I'll get on. What independent tests can be done for sleep apnea after? Okay, so it's pretty hard. If you've had a sleep study before, you've had a tonsillectomy, and now you feel loads better, you'll want to know whether to carry on using CPAP. I would carry on using CPAP until you're seen and have a new sleep study. And I hear that you're waiting for a long time for your sleep centre to get back to you. a lot of the things need to show before and after. So you need to check your blood pressure, for example. Blood pressure before and after a treatment for obstructive sleep apnea tends to be different, because as your AHI goes up, so does your blood pressure. As soon as you fix the AHI, the blood pressure comes back down again. Same thing with blood glucose levels. But you need to have that data before your operation. So it's a very clear sort of linear graph for blood glucose and blood pressure. I guess also you could do subjective tests. So if you felt tired before and you're not feeling tired now, an Epworth score at this stage would be useful. I use STAMP, the questionnaire that I made myself, and there's a video somewhere on my YouTube channel about, I think something, I invented this to help people or something like that. It's basically a questionnaire which is a little bit more rigorous than Epworth score, and I absolutely hate Epworth score, but and it helps you work out if you've improved, particularly after some sort of treatment. So have a look at that if you think that's useful. Barbed suture different to expansion. Okay, I'm actually putting together a video on this. As I mentioned before, I did do a video about expansion, but I felt it was too much for people to stomach looking at that video. But so I didn't actually publish that one. But I am thinking about doing a video comparing a expansion pharyngoplasty versus a barbed suture pharyngoplasty. So basically the difference is expansion pharyngoplasty, which was developed by Kenny Pang, a guy in Singapore, and I'll try and find an old photo of us together, and I'll stick that here, and you'll see us there probably having lunch. I think the photo is. But Kenny Pang, great guy, works in Singapore, fantastic surgeon, worked in America before going back to Singapore. And he invented something called an expansion pharyngoplasty with, I think, Tucker. And basically, there's the palate like this, and the uvula in the middle there. Your teeth are here, tongue coming down like this. And what's happening is this back wall here is collapsing like that. And so the muscles of the palate that come down like this, you take one of those muscles, and it's sort of doing this to you. What you need to do is decouple it from the bottom here. So you cut the muscle here, and then you invert it and push it into this area here. So the muscle goes from here up into there. So you sort of pull the whole throat upwards like this. And it's sort of doing the opposite of what these muscles want to do. It's trying to open you up like this. It works really well. I think I'll show you the data when it comes through in that video, when I get around to doing it. But it's been around a long time. It works very well. It's quite painful, and there's different ways of doing it, but it works very well. Now, actually, a slightly newer operation invented by my friend Giovanni and also Professor Vicini over in Forlì in Italy, called the barbed suture pharyngoplasty. And that's when you use a suture. Again, I'll show in this video, but there's a suture like this with little barbs coming off it like this. So you can push it in this way, but you can't pull it out the other way. And it's useful because you don't have to tie a knot at the end, and people hate knots in their throat. It's just not nice, because this suture stays in your throat for up to 1.5 years. It's quite a long time. And you put the suture in your palate like this, and particularly on the side wall here. And what it does is it opens things up like that. Now, this suture dissolves after a few months, 1.5 years maybe. And when it dissolves, the scar tissue caused by that suture remains and holds everything open like this. So it stops the throat from collapsing like this. It stitches it back and holds it up like that. Those are the main differences. In terms of success rates, they are similar. In terms of pain after the operation, the barbed suture is meant to be less painful. But I'll show you the real stats and data when I put that video out eventually, when I've looked at it. Does RFA to the tongue base help with daytime spool? So if you have a large tongue base, so again with this tongue that's coming down there, so you've got the muscle of the tongue there, back wall of your throat there, and people are worried that this is coming in and blocking their throat. Now, everyone, when they lie on their back, their tongue falls back a little bit. But if you've got lots of tissue there, or a lingual tonsil, a bit of tongue tissue, tonsil tissue, which is sitting on the back of your tongue, it can block your breathing because it feels like that. Now, if you shrink this down, it should give you more air to breathe from. Now, there are some people, and you'll see this in my globus videos. The globus is a feeling of a lump in your throat. There are some people who can feel that lingual tonsil. It feels like really like having big tonsils. You can almost hear it in their voice. If you've got a big lingual tonsil there, you can sometimes feel it, and it feels like it's constricting your breathing. So it's a bit like maybe pushing your tongue back like this. You can sort of feel it at the back of your throat. So this is a long way of saying you can feel it, but it doesn't seem to affect your exercise ability, your performance, and things like that. It's perhaps akin to trying to breathe like this or something like that. It feels like it's blocking your breathing, but it doesn't actually block your breathing as far as we can tell. If you had a strap going around your head like this and pulling your tongue back, I don't think it will significantly change your ability to play sport and things like that. But it would feel better, if that makes sense. If you are actually feeling your lingual tonsil full in your throat, getting rid of that and shrinking it down or ablating it down so it becomes a flat bit of scar tissue seems to help people. But in the sort of tennis players and sort of other sort of sportsmen I've worked with, they say they feel better, they feel great. And when I actually ask them, have your percentage points of improvement in your ability improved? Not really. During the day, they can still run just as fast, but they don't have the sleep apnea and things like that. So obviously, with time, they do get better in terms of their performance. They can build up more muscle, and they're not so fatigued. But it doesn't actually help your daytime sportiness or your ability to breathe. It just feels better. It feels like you can breathe better. I hope you understand that. How many patients suffering with sudden onset tinnitus on average go away completely? Yeah, so I have that video, 2 videos, I guess, on tinnitus. Now, the reason I put that video out is because lots of people who get tinnitus, who are slightly nervous anyway, get very worried when they first hear tinnitus, particularly if they have some preconceived information about tinnitus. So they think that, oh no, I've got tinnitus now, my dad had tinnitus. I'm going to have tinnitus for the rest of my life. He got very depressed because of tinnitus. Oh, I'm only 35. How can this happen to me now? All this sort of thing. And particularly when you go online and you look at the information online, there is a subpopulation of people with tinnitus who've got terrible problems, which is terrible for those people. But what I don't want people, the reason why I made this video is to say to people, look, most people who have tinnitus get better from it. There is a 1% chance of having it for a long time, making it chronic. And even for those people, there is help out there. But I have to be careful what I say, because I don't want to upset everyone with tinnitus. I'm not trying to say that you're wrong or anything like that. Some people get really bad tinnitus, but a lot of people get tinnitus and it goes away completely. And I see it on a weekly basis in my clinic, even though I don't really deal with tinnitus at all. It's not my thing. You should see someone like Kieran Germani or some of my friends who deal with tinnitus. I don't deal with it at all. Even if I don't deal with it, I just give them my talk, which you've seen on that video. And it seems to help people. Well, you go to the tinnitus clinic, that helps people, 90-something% cure rates. But I think a lot of people watch that video and they stop at the point where I tell them, you just have to sort of distract yourself. That's not true. The idea is to continue distracting yourself, training your brain and teaching your brain that it's nothing to be concerned about. And slowly that noise gets quieter and quieter and quieter. And it is difficult at one point because you've set up everything in your house to stop you from hearing the tinnitus, and it is getting quieter. You can feel it getting quieter, but then getting to the point where you no longer hear it at all. Like I can't hear my tinnitus in a quiet room here. Getting from, I can hear tinnitus in a quiet room, but I'm not really bothered by it, to I can't hear tinnitus at all is quite hard, because you have to set up systems in your house to forget that you set up those systems for tinnitus. It becomes your normal routine, and you forget why the radio comes on at 5 o'clock when you walk into the house, or why the radio wakes you up in the morning so you don't hear that morning tinnitus. It just becomes your standard normal thing. And sooner or later, you go, oh, hang on, I haven't heard my tinnitus for a week or so. And then you listen out for it. You can hear it, but it's a bit quieter. And the times when you remember that you have tinnitus get longer and longer and longer. It takes a long time. But back to the question, yeah, the vast majority of people get rid of the tinnitus and it goes away forever. There is a subpopulation of people who have tinnitus forever. Some people have tinnitus, which is really bad, and then gets slowly better to the point where they rehabituate themselves so that they can hear it, but it doesn't bother them anymore. And that's quite a nice place to be. So it's very common to get rid of tinnitus altogether. It's harder if you have hearing loss, and I've talked about it in that video. But if you've got sudden onset tinnitus, no underlying cause, and there's a video about pulsatile tinnitus and other types of tinnitus. If there's no underlying cause, nothing driving that tinnitus, well then it often just goes away by itself. Chronic pressure. Okay, it sounds like you got Eustachian tube dysfunction. I think you're sort of talking about that in your comment. Now, a lot of ENT surgeons go back to using the techniques they use for glue ear to work out if they've got Eustachian tube dysfunction. And I think I think you miss an awful lot of people that way. If you do a hearing test and it shows that the hearing's the same on both sides, that's useful. And it only really changes if you've got like glue ear almost, where the eardrum really can't move at all. Or you do a tympanogram, which is a puff of air that goes into your ear, bounces off the eardrum, comes back again. If the eardrum is moving nicely, then you'll see a difference. It'll look normal to the graph. It'll look like a spike. But only when you have glue ear does it start becoming flattened out or become one of those C-type graphs where it gets over to the left-hand side. I'm not going to explain tympanogram to you, but if both of those tests are normal, a lot of ENT people who aren't really interested in Eustachian tube dysfunction would say, you've got no problem. There's nothing I can do here. I'm very sorry, go away. Now, I think that misses an awful lot of people because, for example, the hearing, you don't get hearing loss so much from Eustachian tube dysfunction. You get, I think, distorted hearing. And there's a difference between hearing less and a distortion of your hearing. So the quality of the sound isn't quite as good. And we don't have a test for that. Hearing a beep and going beep like this with the hearing test is a very sort of crude test to work out if you have hearing loss or not. Because you can hear a beep, that's easy, but hearing a complex sound like speech and being able to interpret it easily, you notice that it becomes easier or harder with Eustachian tube dysfunction or not. And it's not that you can't hear them, you just lose some of the clarity. And some people notice that when they first start losing their hearing with like a otosclerosis or something, and they wear hearing aids and they can hear it, it's a bit louder, but they don't have the clarity, they don't have the character, they don't have the depth of information they normally get from sound. And so I think I heard this from one of my colleagues, Jeremy Larvey, who was doing something about trying to show a test for character, quality of sound, rather than just hearing thresholds, because that's not quite as useful. So I don't personally believe in using hearing thresholds or a tympanogram to look for Eustachian tube dysfunction. I do it anyway, because I think it's quite useful in some cases. But really with Eustachian tube dysfunction, it's a very mild form of glue ear, basically, and often our tests don't pick it up. So the way I tell the difference between patients is to say, look, the only way I'm going to be able to tell is if I make a small hole in your eardrum. I'll let that air escape, let the pressure out, stop the crackling, all those sorts of things. I do it in clinic. You don't even need anesthetic. You just have to keep touching the eardrum a few times until they get used to it. It's a very odd sensation, someone touching your eardrum, but it's not very painful. When you touch it a few times with something blunt, and then maybe something sharp, and then you do cut through the eardrum, make sure you don't touch any of the nerves or the blood vessels, because it just bleeds. You make a hole, less than 1 millimeter in size, and let all the air out and let all the pressure out. And then you say to them, look, go away. I've just banged around with your ear, so don't bother trying to hear it now. But tomorrow morning, if your Eustachian tube dysfunction feels loads better, like, oh my God, it feels fantastic, I feel so good now, then it's likely that you have Eustachian tube dysfunction. And maybe you can have a grommet or a Eustachian tube balloon dilation. There's videos about that on my YouTube channel. But if, and that little hole heals up in 2-3 days' time. So it's like a test. Making this hole in the eardrum is like a test. It is a bit scary when you tell someone you're going to make a hole in the eardrum, but actually, once you get them used to it and touching the eardrum a few times, they relax and it becomes less stressful. And you make the hole, it does hurt like a needle in the arm, but then it goes away in a second later, and people are normally fine with it. But this test suddenly improves Eustachian tube dysfunction for 2 or 3 days, and then the hole heals up and all the symptoms come back again. And if I hear that history from a patient, you did that hole, I felt great for the whole weekend, and the next morning, so next week, on Monday, Tuesday, the hole healed up because every time I did this, the air didn't come out. And I felt worse again, all the pressure and all that came back again. If that's the situation, then I think they have Eustachian tube dysfunction. I don't trust these other tests because I don't think they're particularly useful. Then I would treat them either with a grommet or just tell them to pop their ears constantly, particularly if it's early on in the condition, or a Eustachian tube balloon dilation. So those are the 3 that I know of that work. I can't help you apart from that. I think if you've got proper symptoms of Eustachian tube dysfunction, get a myringotomy and see if that works for you. Chronic pressure. Oh, I've done that one. Muffled at low noise. Oh, yeah, I guess so. With distorted hearing, the eardrum not moving as well as it should do. At low levels, you could still hear the distortion, sometimes even crackling. At high levels, you end up moving the eardrum a bit more normally because it's a mild version of glue. Yeah, it is possible. It's not like there's glue behind the eardrum or mucus blocking the eardrum from moving. It's just the air pressure. So I guess it's possible. This sounds like your own daughter. A 5-year-old tonsillectomy, had 2 adenoidectomies, still heavy snoring. All right, I can't tell if your child has obstructive sleep apnea right now, and I can't talk about personal things, but generally, if a child has had tonsils and adenoids out, and make sure the adenoids are taken out with one of the more robust techniques rather than the curette. The curette has a sort of relatively high risk of it growing back again. But assuming that it's had so monopolar suction diathermy or something like that, and it's definitely gone now, they've looked inside, they've checked that it's gone back, then there are a couple of options for why she may have sleep apnea now. The most common reason is that she had huge tonsils before, and she's got big lingual tonsils before. So you see this a lot in Down syndrome children. When you help them with their tongue-based lingual tonsils, suddenly they can breathe a lot better. Now, Down syndrome have also got hypotonia, thyroid problems, all sorts of other things that cause problems with obstructive sleep apnea. But even with other children, if you had huge tonsils before and they typically have large lingual tonsils as well. So typically when they're lying on their back, their throat gets blocked because of it. So I'd get them checked out, check if they got a lingual tonsil and check if they have a blocked nose. The other one is turbiness, but that doesn't cause sleep apnea. Noise higher or lower for tinnitus? No, I see what you mean. I think people are worried that if you put the noise too high, you get stressed by the noise being too high, the tinnitus goes up, and you're sort of racing to the top, and your noise, the masking noise gets louder and louder and louder, and people are worried, the audiologists are worried that you're going to damage your hearing by blasting noise in and trying to get rid of your tinnitus, and that it's a safety thing. Typically, I would say use a noise which is distracting you away from your tinnitus. I wouldn't have it too loud, and if it's not working at a sort of a low level, then try a different noise. Try something that will actually distract you, music or some radio talking or something like that. You need a distraction. You don't need the noise to be louder and louder and louder. So yeah, try and keep the noise as quiet as possible because we're worried about damage to the cells of your hearing. But I don't think that higher or lower than your tinnitus noise is really that important. Migration of tooth roots into maxillary sinus. So these teeth just about here go into this sinus here. This is a big opening in your facial skeleton. Remember, the face is mostly bone, and if it was solid bone, it would be so heavy you couldn't lift yourself up. So, and you also with these sinuses here, here, and up here, they allow for resonance in your voice. But that wasn't the question. The teeth roots can go into this maxillary sinus, the one just below your eyeballs, in your cheekbones here. And it's very rare for dental problems to go into your sinus. You see it sometimes, but it doesn't really cause sinusitis. You just get pus coming out of your nose, but it's not really sinusitis, because you'd have to have a blocked sinus to get sinusitis. You just get stuff coming out of your nose. But most of the pain is in the tooth, if you understand what I mean. The reason why dentists, understandably, are worried about removing teeth when there's a connection between the sinus and the infection in your tooth is they're worried they're going to make it's called a fistula, like a channel between your sinus and your teeth. So when you eat stuff can get pushed up into that sinus, and it'd be awful, it'll start stinking. So they don't want a hole between the two, and that makes complete sense. So they'll say, oh, go to hospital, get it sorted out there. And there are situations, apparently, I've not seen it before, where sinusitis can cause dental infections. With sinusitis, you do get pain in your teeth because it interferes with the roots of those teeth, but it's very rare, as far as I know, of a sinus infection going down into teeth and causing your teeth to rot or whatever it is. You do feel it in your teeth, but it doesn't seem to infect them. That's my experience anyway. The maxillary expansion question, I think I've already answered this. Basically, I was just saying that at the moment, because it's a new technique, the proper trials, that look at it at a certain time frame with randomization, all those sorts of things, aren't out yet for these techniques. So as far as I know, there's no evidence that conclusively says that these techniques work. And if you think about it, it's expanding the maxilla, which opens up the nose, apparently. Again, as far as I can tell, there's no evidence for that either. But if it is expanding the nose, that will help. And I talked about, blocked nose and the tongue coming forward. But there is a video on showing that the operations on the palate do not help people with obstructive sleep apnea. And I'm sure that you'll be able to find it on my channel somewhere. So palate operations do not help sleep apnea. It's very obvious. There are situations where if you reduce the uvula, you can get some improvement for sometimes up to about 1 or 2 years, but it's not dealing with the root problem. I'll talk about that quickly. If you've got teeth here, tongue coming down like the back wall of your throat there, and the palate, the uvula flapping there, if your tongue is falling back and blocking your breathing, and then your long uvula is coming down and corking your breathing off, so that last bit of airway has been clocked off by the uvula, snipping that uvula or doing some operation on the palate or expanding something and pulling it all out the way is not going to fix your obstructive sleep apnea. It's just going to, because the root problem is the tongue falling back, blocking your breathing in that situation. There's lots of reasons for obstructive sleep apnea. That's just one of them. But if you're shortening a uvula, it does officially help the sleep apnea for a few months, but then the tongue gets worse and worse and worse, and then you get problems all over again. So that was the purpose of that video, to show to people that a palate operation doesn't help obstructive sleep apnea. I'm not sure how maxillary expansion opens up for obstructive sleep apnea, but if it opens up to the point where you can pull the lateral walls apart, that would make sense. But as far as I can tell, I haven't seen any evidence yet. And if there is evidence, I'll be really grateful, because there's another sort of tool in our armory to fight people. I'm not saying it doesn't work. I'm saying there isn't evidence at the moment. And if that paper comes out, I will talk about it on this video, on this channel. Eustachian tube dilation might make CPAP less effective. No, you're worried that the air will suddenly go into your ears rather than going down into your throat. That won't happen. The airway is huge compared to the tiny little holes with the Eustachian tubes. Now, if the pressure is very high, then you'll find that CPAP goes into your ears and makes your ears pop all the time. And that happens to normal people all the time. But it won't make it less effective. Possibly your pressures are too high, or there's a real obstruction like big tonsils or a tongue-based problem or a lingual tonsil problem, which is making the pressure so high it's going into your ears. But it doesn't make CPAP less effective. You may notice symptoms in your ears afterwards now that you've unblocked your Eustachian tubes, but it doesn't make it less effective. Show videos of tonsil shrinkage. It's quite hard. I don't ask every patient if I can videotape them, but yeah, maybe I'll do another one if I can remember. I've just done a few recently, especially a very nice guy who gave me some wine or champagne. Yeah, some wine. Thank you very much, the chap from Israel. But yeah, I'm trying not to do lots of videos on operative videos. I will do some, obviously, because I think it helps some people. But yeah, just look at that video and hopefully it'll help you. I don't see how looking at the video really helps people, but if you can convince me otherwise, maybe I will do some more videos if people actually like them. What's my Epworth score? Yeah, I kind of hate Epworth score. Like, it's not a questionnaire. Epworth score is a way of measuring daytime tiredness. That's really useful for daytime tiredness. But I'm jet lagged. I'm on call. I don't have sleep apnea because my Epworth score is high. Single moms with 3 kids, they're tired all the time. Doesn't mean they have sleep apnea. So my worry is that people use the Epworth score as a screening test for obstructive sleep. Oh, you're not tired enough, therefore you don't have obstructive sleep apnea. I'm not going to put you forward for a sleep study. I think that's wrong because it is not and has never been validated for that use. It's not useful for picking up people with obstructive sleep apnea. So you should not be using it for that reason. What it is useful for is saying to people, look, we know you have obstructive sleep apnea and we know you're very tired. Therefore, that group of people who are very tired and have moderate to severe obstructive sleep apnea seem to do very well with CPAP. And I'm guessing is because when you wear CPAP, even for a few hours, you feel so much less tired the next morning that it feels so worth it that despite all the leaks and the pressure and all that sort of stuff, you want to carry on using it. Those people love it so much that they will not let anyone take that CPAP away from them because it makes them feel so much better with it. But not every person with obstructive sleep apnea is tired. A lot of people, most people, aren't tired with obstructive sleep apnea. They just get more sleep, or they just work harder on their sleep, or they sleep for longer, and therefore they get the amount of rest that they need. And although it's poor quality sleep, they are getting enough, and they can power through the day with coffee and adrenaline, and they fall asleep very quickly when they get home, and they sit with their wives and try and watch TV. They fall asleep straight away. But an Epworth score in those people, they would say, well, I'm not that tired, because they've forgotten what their normal is. And when you get rid of their sleep apnea or their problems, suddenly they realize how tired they used to be. But I'll go on, I'll talk about that later. A device that doubles as a retainer and a mandibular advance device. Yeah, I've asked this before. I know nothing about dentistry or maxillofacial surgery. Apparently there's not. But I have noticed quite a few people using a tongue retaining device, a bite relaxing splint for mandibular, temporomandibular joint dysfunction. They find that when they wear it, their sleep study results look better than when they don't wear it. As I said, I'm not an expert when it comes to these things, but I think there is something in there, but I've not researched it, and I don't want to upset every single dentist watching this video. I'm sorry if I said something terribly bad. Breathing through the nose, swallow air, deviated nasal septum. It's hard to tell from what you've written. If what you're saying is right, you get aeophagia only when you breathe through your nose. It sounds like, it just feels like, if you've got a blocked nose and you're trying to breathe very hard, you do get a bit of air going into your stomach. But I can't quite tell what you're talking about in that comment. But hopefully, just fixing your nose will help. And to know if you can't breathe by breathing through your nose because of a deviated nasal septum, you just close your mouth and see how long you can last. If you really can't breathe, then, and it's all going in, so you blow all this air out, then you know that that's true. But I suspect it's just that you feel like you just can't breathe through your nose because it's deviated. Palate surgery. Yeah, so I've talked about that video where I say that, using a palate operation for obstructive sleep, it doesn't really work. It helps for a short time, but it's not dealing with the root cause. It stops the snoring for a short while, but if the obstructive sleep apnea is still there, it'll still stretch and cause more redundant tissue later. Within 5 years, most people who've had a palate operation will come back saying, I've got all my problems again, and you have to go through the cycle again. And there's only so much you can cut out of the palate before you can't cut out anymore, and then you're stuck on CPAP. And when you've had, particularly with laser cutting through a palate, people worry that CPAP doesn't work quite so well because it ends up coming straight out of your mouth. So it's not an operation that I do. And there was some papers about certain types of laser operations of palates being actually worse for obstructive sleep rather than better. But it's not something we know much about. Some people who do these operations have very good results. It's just not something that I do because I'm worried about the research data on this. Sense of smell from one side of your nose after surgery. So does that mean when you're breathing through both nostrils, you can smell again? It sounds like you just got a blocked nose on one side, because if you block your nose, you can't taste or smell anything. Why don't you go back to your surgeon and find out what's going on? Because it seems odd. But if you can breathe, if you can smell things from the other side and not on this side, it sounds like you just got a blocked nose on one side, or there's blockage at the very top, and it just needs to be cleared out. Sometimes some of my colleagues put sponge in the nose, and that just comes away, and you can start breathing again. But yeah, someone needs to check your nose. Yeah, there's loads of things. So yeah, I've been around a long time, I guess. So when I started, I used to, when people came in with a heart attack and I was in accident emergency, I used to thrombolize. I used to give them a drug which should dilute all the clots out or disperse all the clots. It was a terrible conversation. I said, look, I'm very sorry, you've found that you've had a heart attack. There's a clot blocking one of the arteries to your heart. We're going to give you this drug, which will hopefully disperse that clot so you can, so the heart can open up again. But it may also cause a stroke and you may die. And they're like, oh, can you just sign this before I inject this? And it's very hard to make that decision when you're having a heart attack. And these days, you send them to the cath lab, they put a wire down and they dilate everything open and they're better again. It's a much better technique. Talking about, actually going back to that thing about impact, a patient who's had most impact on me. I remember in one of my first jobs in ENT, there was a lady who came from America who said that she had an operation for snoring and obstructive sleep apnea. And it was a laser operation on her palate. And she'd been left with a nasopharyngeal stenosis, which means that there's very little air escaping behind the palate. She was so unhappy. She could barely sort of cope with it. It's a horrible condition to have because someone had tried to use the laser without protecting the back wall of the throat. And so the palate had stuck itself to the back wall of the throat and she was just breathing through this tiny little hole. That's why hardly anyone does UPPPs anymore, or unless they've got big tonsils. But UPPP is not an operation anyone who's serious about sleep apnea does anymore, or laser techniques that without any protection onto the back wall, because everything just gets stuck back. It's a horrible situation to be in because it takes, this is one of the first things I learnt when I did sleep surgery as to how to fix that, because the people I meet, I can, detach it and do a couple of operations to get to the point where they can start snoring again. And to them, that's a great improvement. And then you try and fix their palate, and so it starts being functional again. But yeah, that is something that the people no longer doing UPPPs and laser operations without protection is a big change, I think, at least in sleep surgery. yeah, I can't tell from your description about Eustachian tube if it, you're saying there's a sticky noise when you're breathing through your nose. It sounds like you have a partially obstructed Eustachian tube. I'd go and see someone, get it checked out, and get it looked at. People will worry about patulous Eustachian tube, that the tube is too open and air is passing backwards and forwards. But I think you've just learned a way to open up those muscles, because there are a couple of muscles around the Eustachian tube orifice that can be opened up, and breathing through your nose has trained you to open up that Eustachian tube. But if you're, as you say at the end, your hearing sounds blocked again afterwards pretty quickly, that may well be your Eustachian tube blocking again. So yeah, I just get checked out by someone and get it looked at. Are there any more? No, that's it. Hopefully you found that useful. Maybe I'll do it next year if this video, really long video, takes off. Anyway, Merry Christmas. I haven't been called for my operation, which is great. 46 minutes, wow. Do take care. Bye-bye.